It works. Hello, everyone. So, let's see that. Okay, that was one of my drawings, like at one of the times. So, yeah, I would like to explore colors, lines, shapes, and come up with something like, yeah, it may represent a specific energy that I feel this time. Hi, welcome back. I'm doing another part of smoking as a maladaptive health behavior and its correlation with ACEs, adverse childhood experiences, and obesity. So the link between the three is all into psychophysiological and psychosocial distress. So everything as we explore together is built up in layers. As I mentioned before, we are trying to build the onion of the human condition. It is complex. It is composed of multiple matrices, and nothing, no one size fits all, or there is a clear picture of why something is happening. Everything needs deeper analysis, deeper understanding. But however, to understand what most like the when we try to understand a scenario or a narrative, we would like to know the main players, the main players of the scenario or the narrative, the main players. There are masterminds, they are the thinkers, they are the plotters, they are the one who understand the ins and outs of any schema, and there are sub players. And if you understand, this is how the social context is designed. So it is so interesting that everything is work as supposed it works with the grand narrative of human condition. And then we understand the outsider players, like something like it's not accounted for, that's like the viral infections or the pathogens or anything like that, or aging, that factors that accelerate aging are not accounted for or expecting at such specific. So we are trying to do the framework of the narrative. So every narrative has a framework, it has concepts and context to go within. So everything has matrices we follow to understand um, the core influence of the narrative, and not the story. The story is like a timeline, happen first, then next. It's one event or two events that correlate with the main narrative, but they are part of the narrative, not the whole narrative. So we try to understand this. Thereby, we are bringing major players in health and disease. We have a huge narrative. It's called health and disease. We have an onion to peel. We are trying to understand a part of this layer to present us a solution, or to present us with understanding what best approach we can take. Other another part of the matrices, we have to understand your population. Not every depend on race, ethnicity, age, gender, sex, political affiliation, religious affiliation, attitudes, beliefs, attributions. Some relate their behavior because you did this to me, that's why I'm doing this. So the blame shifting or the blame game, he did this, that is why I'm doing that. So that part embedded in our heuristic or our the ready to use familiar or relevancy, because the brain looks for relevancy as well. That is part of the neuro language, is looking for relevancy. Is it relevant to me, to the what I have already? It's familiar. So here the body understand this and act accordingly. So in this grand narrative, we are presenting other uh, we see not master players. Maybe they consider like it depends on the context, so they can consider master players or sub players. So we have one of maladaptive behaviors is smoking. As I mentioned before, if you ask any practitioner what number one behavior you want anyone to stop doing, they are gonna ask their answer is smoking. Smoking is related, and I hope I can bring this. I'm going to bring the attachment theory, because based on the another part of the equation is adverse childhood experiences. And at least, so everyone at least went through one adverse childhood experience or one type of trauma, at least one. And I'm not saying two or three or four, at least one. So nobody is immune, because this is the human nature or the human condition with the complexity of socio or geopolitical, socioeconomic, uh, psychological distress. It is based on the inherited load of toxic emotional load and inherited sub-schemas of conflict, lack of social support. So everything is building up. It's nothing is like comes from void, or that is who I am. So here it is. Deal with it. You are complex, you are multi-layered. What you see is a mask, and sometimes you see hundreds of masks. This is the adaptation, the camouflage, the survival. So every situation has a specific mask to put on. Every situation has a specific personality. By the way, you are not one personality, you are multiple personalities, because it's based on survival. You don't have one identity, you have multiple identities, because it is based on survival. What makes you survive since 7 years old till older is gonna show up in the behavioral patterns and in social connections, communications, situations. How you handle a specific tension, conflict, stressors is gonna show up. Is gonna show up. So whatever, so you are an outcome of your a adaptation of sometimes it is very toxic, it's unhealthy patterns of survival, because it causes harm where the other person you didn't know or anything, but they happen to be in the wrong place, wrong time. The wrong place at the wrong time. So why it happens wrong place, wrong time? So in the other healthy pattern, you say, I was in the right place, right time. So see how things or the dynamic of behaviors or adaptation of specific behaviors. And when it comes as a survival mood, and the individual get the outcomes that they desire, which is the whether they are battling the pain pleasure scale, so if they would like to numb their pain, so what they are seeking at this moment, if they would like to escape or zoning out from their discomfort of lack of social support, feeling not belong, not fit, a mismatch, outcast, or whatever. There is no healthy attachment from early childhood. So that is, and mostly with smoking, some of the psychological explanations, but I don't know what is the root of it. It is the deprivation of the nurturing during the R, um, the bonding between the mom and the child, it was disrupted, so they feel like sucking their thumb or smoking, so this makes them feel attached to something they missed at early age. So that is one of the explanation for smoking. And whoever had this disrupted attachment pattern between the mother and the child, you're going to see the first thing they are seeking is either sucking their thumb or smoking. So it is like alternative for their soothing, for their numbness, for their escape, for their like, I don't know exactly how, but my central nervous system is overwhelmed now. But they don't say, oh, central nervous system, I am going through the motion. I am triggered. I am not comfortable. So I want something to attach to zone out or to feel this sense of pleasure. However, it is temporary. It is not lasting effect. It is not long time because the stressor is already exists. The emotions hasn't been dealt with. The trauma left unresolved and unaddressed, so that the adaptive behavior or maladaptive behavior continues. But what this does in your biological systems, from culturally standpoint or health culture, no one taught everybody or anyone um, how to understand the missing piece of healthy attachment, healthy upbringing, healthy personal interpersonal relationships, healthy processing of emotions. That is not a culture in any way. So here I am opening up to understand we have to shift our dialogue. We have an open dialogue. To have a state of disease, that is not what God meant for you. God meant for you is a life, and a life with abundance. And when things happen, they are not the norm. They are not the case. They are the exception. But the case God sent to you for a purpose to do things as He did. He did lots of good things to us. So we are a followers. We are God's offspring, so are His children. So He wants us to follow through His sense of creation, His sense of bringing new life, bringing a change, but for the better, not for the worse. So I am continuing this second part of smoking, adverse childhood experiences, and obesity. Because obesity, it is based on first the child inherit their body composition from mom. Okay, so whatever. So and the genetic composition, the metabolic, everything, like it's like it's a small model of the biological composition of what has been processing through the neurodevelopmental stages from 10 weeks of the neurodevelopment of the neural tube development. So your central nervous is your core. That is who you are, your central nervous system. the brain and the spinal cord, and including all the nerves that is connecting the compartment, what we call the body, and the biosystem to function, uh, to compensate, to communicate. So if there is a chaos in this the composition, there is wrong signaling, and there is misreading for the cells, among the cells. So there is a representation of other predisposition or other mutation or proliferation of a specific biological mechanisms. So you are very complex, but the main thing is your central nervous system. That's if you don't have a strong a strong upbringing, or the parents have gone, or the mom especially gone through a lot of trauma history, stress during pregnancy and before, that impact the sensitivity of the central nervous system. So behavior is not only what you see. Behavior is what happened internally, and this then manifests in impacting your mood, your memory, your perception, your connection, your methods of communication, and all of that. But it depends on attenuation, focus, attention, understanding, the ability to process complex context. It is not the ability to understand abstracts. So all of this leading into correlate to your health and disease, and what system are you function from. So we have to understand there is metabolic metabolic processes occurring, electrobiochemical metabolic processes that affect the cell, tissue, and organ system, their health and disease status. So let me continue, and I am going back to another factors or another players in smoking, adverse in childhood experiences, and obesity, and that is the sympathovagal imbalance. So it is the disruption in the normal balance between the sympathetic fight or flight and parasympathetic rest and digest branches of the autonomic nervous system. In the context of obesity, particularly in women with high visceral adiposity or adverse childhood experiences, this imbalance can contribute to cardiovascular diseases, metabolic syndrome like type 2 diabetes, and poor stress regulation. The sympathetic nervous system activates the physiological responses like increased heart rate, blood pressure, and metabolic mobilization like glucose fat breakdown. The parasympathetic nervous system, or PNS, primarily through the vagus nerve, the 10th cranial nerve, slows heart rate, promotes digestion, and support recovery. The balance between those systems allows for the adaptability to stress, efficient cardiovascular regulation, and metabolic health. Sympathovagal imbalance refers to a psychological shift in the autonomic nervous system, NS, where the sympathetic nervous system is covertly dominant relative to the parasympathetic nervous system. This imbalance disrupts physiological homeostasis, contributing to increased risk of cardiovascular, obesity, metabolic syndrome like type 2 diabetes, and emotional dysregulation. Like the sympathetic nervous system is fight flight, increases heart rate, blood pressure, glucose, and cortisol. Parasympathetic nervous system, so rest and digest, slows heart rate, enhances digestion, promote recovery. A healthy system maintains a dynamic balance between the sympathovagal, the sympathetic and the parasympathetic. However, the sympathovagal imbalance happen when the sympathetic nervous system is overactive, or the parasympathetic nervous system is underactive. In obesity, excess visceral fats produce pro-inflammatory cytokines, as we mentioned before, interleukin 6, tumor necrosis factor alpha, activates hypothalamic pituitary adrenal or HB axis, and impairs the vagal tone. Visceral adipose tissue releases leptin, which stimulates the hypothalamic centers to activate the sympathetic nervous system and suppress vagal input. So this is hyperarousal, this is hypervigilant, this is impulsive. That is all the activation and correlated with oxidative stress as well. In trauma or ACEs, women who are exposed to adverse childhood experiences and prolonged periods of trauma, chronic stress from adverse childhood experiences, train the autonomic nervous system toward the persistent sympathetic arousal and blunted parasympathetic. Reactivation, sometimes described as autonomic rigidity. This results in reduced heart rate variability and poor recovery after stress. A heart rate variability is a gold standard non-invasive biomarker of sympathovagal balance. So, if it is high, we have a strong vagal, parasympathetic vagal tone. High frequency dominant parasympathetic input. Low frequency or high frequency lead is sympathetic dominance. So the consequences of that, we have the predisposition to cardiovascular disease, hypertension, arrhythmia, myocardial infarction risk, insulin resistance, hyperglycemia, visceral obesity. We have anxiety. This is a psychological state, the psychophysiological state, anxiety, emotional dysregulation, trauma persistence. From endocrine, we have chronic HB axis activation, elevated cortisol, reproductive disruption. For premenopausal women, estrogen promotes parasympathetic tone and maintains lower frequencies, high frequency ratio. For heart rate variability, postmenopausal women, estrogen loss causes a shift toward the sympathetic dominance, especially in obese women with high visceral fats. Trauma exposure and ACEs leads to this imbalance become more pronounced, the compounding emotional and metabolic risk. The low frequency, high frequency ratio stands for the low frequency to high frequency ratio and is widely used indicator in heart rate variability analysis. And to understand the frequency dominance. And the information can be obtained through the electrocardiogram or photo polysomnography or PPG or ECG. The heart rate variability is the variation in time intervals between consecutive heartbeats. It reflects the heart ability to respond to a variety of physiological and environmental stimuli. In frequency dominance for heart rate variability analysis, the RR interval signal is decomposed into its frequency component using methods like fast Fourier transform or FFT or lump spherical parallelogram. The resulting power spectral density (PSD) reveals how power variance is distributed across the frequency bands. Understanding the low frequency, high frequencies, or the heart rate variability, dominance, or matrices, it serves as an index of autonomic nervous system balance, specifically between sympathetic nervous system, fight, flight, and parasympathetic nervous system, rest and digest. The low and high ratio attempts to capture the sympathovagal balance and the balance between the sympathetic and parasympathetic activity. For low frequency linked with both the sympathetic and parasympathetic activity, strongly associated with baroflex activity, blood pressure regulation. High frequency power reflects parasympathetic vagal activity, strongly tied to respiratory sinus arrhythmia. The natural variation in heart rate during breathing. The higher like low frequency and high frequency suggests increased sympathetic modulation or reduce the vagal tone. Low frequency and high frequency suggest parasympathetic dominance, often associated with calm, restful state. For low and high frequencies ratio, it is like a mirror for cardiac health and health prediction. For myocardial infarction or post myocardial infarction mortality, assessment of autonomic neuropathy in diabetes, monitoring recovery after surgery or trauma. It provides biofeedback and mindfulness programs. Use low and high frequency gauge stress levels. Elevated the low frequency high frequency ratio is often associated with anxiety, mental workload, and emotional stress. Low frequency is purely sympathetic, and sometimes it is inaccurate to interpret low frequency as a direct measure of sympathetic activity alone. Breathing rate affects high frequency. Slow breathing during meditation can artificially increase the high frequency power and lower the low frequency high frequency ratio. So, low frequency and high frequency ratio is a valuable biomarker of autonomic function. That is the sympathetic, parasympathetic, fight, flight, rest, digest, or calm. But it must be interpreted consciously and contextually within a narrative or within a scenario or within a case study. So it is not interpreted the same results for everyone. It is based on the context and the input and the processing of the analysis. It can help track stress, fatigue, resilience, and recovery, but it is not a standalone diagnostic tool. For example that in clinical setting, in sports, in personal health setting, it is preferred to be combined with heart rate, other heart rate variability matrices, and contextual factors like sleep, mood, workload, age, the density of the visceral fats, like BMI can be one of the biomarkers as well, because it's correlated. It can measure leptin disturbances or dysregulation. So another measurement is using the root mean square of successive differences. That's another matrices or another measures. Overall, heart rate variability influenced by both sympathetic and parasympathetic branches of the autonomic nervous system. There has to be there is a recording for longer periods of time to understand the average calculation or the baseline of the person. For heart long, like 24 hours recordings. There is a study is the heart rate variability and cardiac vagal tone in psychophysiological research, recommendations for experiment planning, data analysis, and data reporting. That is from Frontiers in Psychology. The study present a recommendation for synthesizing information of 2 decades of heart rate variability research, aiming to standardize methodology across psychophysiology, behavioral medicine, and affective neuroscience. So that is a multidisciplinary. So the approaches right now, we are not like organ system. It is biological systems and metabolic function and dysfunction across disciplines. So in these 2 decades analysis processes or collecting data, trying to understand the commonality or the gaps or the what is the outtake of this paper, what the takeaway points. It is the methodology across the psychophysiology, behavioral medicine, and affective neuroscience. Affective neuroscience is always emotions like depression, anxiety, and other disorders or a spectrum of disorders, clusters of disorders. Its goal is to provide a clear clinician and researcher friendly roadmap for assessing cardiac vagal tone in heart rate variability. It was tailored for hospital psychologists, sport scientists, doctoral researchers, and small labs seeking practical, actionable guideline without wading through dense methodological sections. The recommendations that prioritize RM, SSD, and HF power as a reliable indices of parasympathetic vagal activity. Avoid the LF and HF ratio, which the author caution is physiologically ambiguous. The structure studies with phases of resting, reactivity, and recovery to assess autonomic flexibility and response dynamic effectively. Use of high fidelity equipment, for example, like ECG, sampling roughly 5 minutes while monitoring respiration, even if not adjusting for it to yield robust gold standard data. Ensure statistical power is higher than 61 participants for between subjective design, and consider within subject design when sample size are smaller. Some of the data analysis reporting is adopt the graph checklist to ensure comprehensive reporting from participant selection to heart rate variability calculations. Share raw data and the analysis scripts via platforms like OSF to facilitate replication and error checking. Not all experimental or every theory or methodology is could be replicated. Some are going to see the efficiency, the fidelity, the feasibility of the studies, because we build on those who already walk the walk and did a lot of studies. So, but however, what is the context? What is the environment? What is their perceptual hypothesis from the beginning? And if it is so, and if the experiment has been redone, will they be able to replicate the same outcomes, or there will be other results or a new understanding for all the findings. So always report the breathing frequencies alongside RM, SSD, and IHF power to discern whether variations result from true vagal modulation or simply changes in respiration. The context is important. The scenario is important. Reading the details and the graphs and the method, the discussion, the introduction or the abstract can give a different point of view, particularly when we are working from multidisciplinary approach. Every discipline is gonna look for the validity from their own specialty or their own understanding or knowledge. However, when we correlate all these knowledges and we see, okay, how come we integrate all systems or disciplines and provide something more comprehensive, more unique to the cases that we are presented, and we can do the correlation or the association between theory and practice and provide evidence that can be generalized over disciplines or on other studies on other population. The authors distill complex signal processing literature into clear behavioral and methodological principles. They recommended valid vagal indices, RMSSD, HF power. Three are experimental design. A high quality data collection, fast sampling, respiration monitoring, thorough reporting, and openness. Together, these practices promote replicability, facilitate small lab access, and strengthen meta-analytic potentials. working across disciplines and creating labs that work on a specific data entry and following the methods in the analysis in the procedure that can lead to an outcome or results that can benefit other labs or other studies. That what majority of researchers, scientists, is practitioners are trying to collaborate and understand what you're working on and how this can contribute to what I am working on. And this is all the benefit of advancing science and contributing to the discovery of new therapeutic approaches, biomedic techniques or strategies, and understanding cross discipline. A cross discipline is something we are calling for right now. It is not only physiology, psychology, behavioral. It's all interconnected. It is all presenting the human condition. It's all presenting why people do what they do, act how they act, and behave the way they behave. So we have to understand this complexity of matrices across discipline. They requested that the reduction of the methodological inconsistencies. Some studies present inconsistency, so you have to be the expert in this field to be able to understand the gaps, the track of the start from the hypotheses or the idea or the thought and following through with the proper measures, procedures, and methodology, data analysis techniques or methods, and how to interpret into visualization through graphs, tables, or presentations, and then presented the outcomes in correlation with a specific population and why this population is more at high risk than others, and count for the outliers. I count for the outliers because this is when true havoc occurs in any community or any society or any family. Outliers are presenting us with the extreme pathophysiology, pathopsychological differentiating factors, and many are it is hard to get the right data the right time, and it's all based on what is available right now. So still there are limitations in every study and every practice. There are still many limitations. If we change the conversation of the human health or the health culture and the human condition, we are going to be more open what we need to screen, what we want to focus on, and we shift from the conventional traditional understanding of health that the human is a separate entity. And because of the familiar history, yes, familiar history can contribute a lot. However, the environment can radically present other trajectory for human health and disease. So we have to be open to this dialogue. It's not easy. Everyone maybe like they are comfortable on what they do, and opening to the change can occur gradually. For vagal markers, recommendation of using RMSSD and HF power, avoid LF HF ratio. The framework of incorporate resting, reactivity, and recovery phases. So you have in the parasympathetic, you have sympathetic, and you have the recovery after the exposure to the stressor or the stimuli or the event that activated the sympathetic. So the increased cortisol, hypervigilance, irritation, impulsiveness, and multiple and maladaptive behavior to take place. The standards is use graphics checklist, share raw data and scripts, and inspect data visually. So reporting breathing rate alongside heart rate variability matrices to aid interpretation. So it depends on the context, it depends on the event and the state of the person at the moment when the event took place, or when the analysis or over monitoring for 24 hours took place. So, is improving sympathovagal balance is possible? So, some of the recommendation is aerobic exercise, improve RMSSD and HF power. Mindfulness meditation, because this is the parasympathetic, rest and digest based breathing, enhances the vagal tone, reduce LFM HF ratio. Trauma-focused therapy restores autonomic regulation in ACEs exposed individuals. However, women who are exposed to adverse childhood experiences and other forms of trauma may present the community, the society, or the environment they are in with their development of chronic physiological dysregulation. When combined with obesity, especially visceral adiposity, and these women frequently exhibit a pronounced sympathovagal imbalance. With elevated sympathetic nervous system activity, reduced parasympathetic nervous system tone, and the imbalance increases the risk of cardiovascular, metabolic syndromes, and mental health disorders. Once the allostatic load is in place, we understand that the condition will be either present itself, progress, or follow a cluster of conditions. So your metabolic dysfunction or your sympathovagal imbalance is not presenting your body with one condition. It is a cluster. And all are playing or feeding on each other, because what is the current neural messaging or the cellular signaling, what state they are confused, inflamed, and there is a load of excitotoxicity ratio. Trauma exposure during the sensitive developmental periods, we say from 0 to 5, from 7 to 9, and from 9 to 13, 16, and 19. These are the critical stages of any development. What context is presented in the environment totally it has a heavy impact on the neuropsychophysiology, impacting the immune system, impacting the state of disease, impacting the state of attenuation, focus, memory, perception, and the list goes on. Repeated toxic relationships, choices in life, and It is chaotic internally and externally. It is not the state of rest and digest and feel comfortable and safe and you are cared for and nurtured. No, it is chaotic. And when the body acts from this chaotic states, they seek numbness, denial, escape, anything to suppress this overwhelmed state of the central nervous system. So the exposure to trauma during the sensitive developmental periods causes longer-term HB axis dysregulation, heightening cortisol and catecholamine secretions. The chronic stress response sensitizes the central autonomic network, including amygdala, hypothalamus, leading to persistent central nervous sympathetic nervous system overactivation and diminished of vagal modulation. The visceral adipose tissue secretes inflammatory cytokines like interleukin 6 and tumor necrosis factor alpha, and adipokines like leptin, which further stimulates sympathetic overflow and reduce parasympathetic activity. Uh, so for obese and overweight women, particularly postmenopausal, exhibit higher muscle sympathetic nerve activity. MSNA, correlating to visceral fats. Trauma amplifies stress-induced sympathetic tone. Obesity potentiates inflammation and sympathetic drive, creating a vicious cycle of autonomic imbalance. Hypervigilance, impulsive, uh, not calm state. You see that you feel the energy. Once you walk in, you see the person on edge. You see it from their eye. You see it from their shoulder, their steps, their hand stretching, their arm stretch of arm. That tells a lot about the sympathetic or the vagal tone. So your body is presenting external language for others to pick on. And once you present this activated or overactive sympathetic tone, the perpetrator seek that because you are distracted and you are overwhelmed in your chaotic response. They look for that. It is tough when you walk into an environment and you understand what you present is not yours anymore. It is somebody else to use or abuse. So that is away far, like from any clinical setting, from any masking or any framework is presented from the outside. But what really is occurring, your body language, your facial expression, your vagal tone, your tone of voice, and your sympathetic response or parasympathetic response is presenting an opportunity for use or misabuse. The words you speak, your relationships, who you are connected with, your mind, because the perpetrator is after compromising the mind. And this is another core of the human condition. Disrupting the heart. So that is what we say in the sympathovagal balances. So it's all environmental. what stimulates, what triggers, what activate, what is the load has being done onto the human biosystems. It's not only what you eat. It's not only what you eat, what you drink. It's what is the environmental narrative or context. And that is very based on the developmental stage, age, gender, race, ethnicity, um, a mental, emotional state, psychological state, stress, the psychological distress. Psychological stress means a distraction, another opportunity for the perpetrator. So you understand that we are, as human, we already exceeded what is presented in the media. The media is just like a copy of what is partial happening in real life. It is disturbing, it is distracting, and it presents to humans with another perspective, still trapped in the reptilian mammalian brain and not elevated to the human brain. That is the prefrontal cortex. That is what the perpetrator is after, is to compromise the prefrontal cortex. So once they compromise the prefrontal cortex, so the mind and the heart, that you have a compromised biosystem and compromised object. They call us objects, not humans. So we are objects to use, not humans to live. So that is hard concept to grasp from the environmental narrative within the socioeconomic context, political, religious, and other factors that humans are not be seen as humans anymore. There are multi-masks, multi-layers, and that drives the sympathovagal, drives the quality of life, drives the health span, drives the mortality and morbidity. It drives everything. It drives inflammation, drives sleep patterns or sleep disturbances. So it's all correlated. So you have a complex matrices of stimuli or modifiers that disrupt the imbalance of the vagal tone. So that drives obesity, eating disorders, aggravate the genetic predisposition for cases like the bipolar 1 and 2 and schizophrenia. So and the human is a device, came with specific programming. It is basic and it is pure and fragile. How it is reprogrammed through the world and the experiences and the input and the disturbances that compromise the human condition. So I challenge that many out there have been exposed and been disrupted and began to question their reality and their basic or the pure or the baseline identity has been fragmented, and they started to build the different identities on survival, putting more masks on survival, and that they don't know they are compromising their biological system and overloading their central nervous system. So obesity and potentiate inflammation and the sympathetic drive, creating a vicious cycle of autonomic imbalance. Emotional and behavioral consequences like emotional eating, exercise avoidance, reinforce obesity and stress. So reduce the heart rate variability. Obese trauma exposed women show lower RMSSD, lower than 30. and high low FHF ratios, higher than 2.5, indicating sympathetic dominance. Sympathetic dominance, fight, flight, freeze. Freeze that you don't want to talk with anybody. You don't want to go anywhere. You don't want. It is losing the sense of self. And this is a hard state when humans, we see them gradually, their system shutting down and giving up their lives. It's a survival mechanism. Indicating sympathetic dominance, MSNA recordings reveal elevated sympathetic bursts are correlated with visceral fat, increase the likelihood of hypertension, arrhythmia, and myocardial infarction, insulin resistant glucose intolerance, further obesity progression, higher rates of anxiety, PTSD, and emotional dysregulation. Behavior therapies addressing trauma, like trauma focused CBT, mindfulness based stress reduction, improve vagal tone. Physical activity, reduce sympathetic tone and visceral fats. Pharmacological approaches targeting sympathetic nervous system activity, like beta blockers, may be considered. Integrated care combining psychological and metabolic treatment offers the best outcomes, because what has been triggered and disrupted the balances in the metabolic function, we have to go back to metabolic function and we address what disruptions have been taking place. ACEs and trauma exposure outcome is hypothalamic pituitary adrenal axis and sympathetic nervous system hyperactivation, elevated sympathetic tone, excess visceral fats, inflammatory cytokines, leptin dysregulation, further sympathetic nervous system stimulation, and parasympathetic withdrawal. Sympathovagal imbalance increase the cardiometabolic and emotional risk. Vagal tone refers to the activity of the vagus nerve, that is the 10th cranial nerve. We have 12, the primary component of the parasympathetic nervous system. It regulates the cortical functions such as heart rate, slowing it down, gastrointestinal activity, inflammation control, stress recovery. Low vagal tone means reduced activity or responsiveness for the vagus nerve, indicating diminished parasympathetic influence over body systems. The most common non-invasive biomarker in heart rate variability, especially metrics like RMSSD, or root mean square of successive differences, and high frequency power, or HF. Low values in the matrices signal reduced parasympathetic vagal tone modulation. Low vagal tone associated with cardiovascular dysfunction, elevated resting heart rate, hypertension, increased risk of arrhythmia, metabolic disturbances, insulin resistance, poor glucose regulation, obesity, and metabolic syndrome. Inflammation, the vagus nerve exerts an anti-inflammatory role via the cholinergic anti-inflammatory pathway. Low vagal tone correspond to increased sympathetic inflammation. Psychological and emotional regulation problems, increased anxiety, depression, PTSD, and poor stress resilience. That is trauma talks. When I say the trauma bleeding, if we understand what, but however, there is intergenerational trauma and racial trauma. People hate on each other, even they didn't anticipate in what originally took place decades or centuries ago, but it is like feeding on because it serves a function, it serves a purpose, fueling all this sympathetic and low vagal tone. It serves a function and a purpose. It has a specific outcomes. But however, the human value, the human uh, existence is questionable. It is now is highly questionable. And what is the right pathway for a human to exist with this complexity that presents itself? Sometimes you avoid it, but it's pushing its way onto you, even you don't anticipate or participate or declare that you don't want to be part of it, as if it is like like a life sentence or something. So we have to understand what exactly human mean, what health means, what healthy culture means, what does it mean with a human existence, their rights for a life, what are their rights for life, and what life means in the eye of the beholder. Many questions. For low vagal tone, early life stress blunts vagal tone, leading to a chronic imbalance skewed toward the sympathetic dominance. Excess visceral fat promotes inflammatory cytokines and leptin secretion, which impair vagal function. The combined effect in trauma exposed obese women leads to a particularly low vagal tone, amplifying health risks. Some of the regulation for the vagal tone, like aerobic exercise, increase heart rate variability and vagal tone. Mindfulness meditation and breathing exercise enhances vagal activation. Psychotherapy, talk therapy, talk it. Whatever doesn't find itself in words, find itself in organs. Bottle up buttercup is no longer valid for the intentional and unintentional harm. It's not valid anymore. But bottle up buttercup? What? Um, I understood this late. But anyway, moving on. Psychotherapy or talk therapy is critical. How to find this safe space when your voice is being I'm not voicing my voice to condemn. I'm voicing my voice to address a concern. How far you're addressing for any concern is being perceived, is being respected, is being accepted, is gonna tell you, are you in a healthy environment or unhealthy pattern or dynamic? Green flags means kindness, compassion, ability to hear or listen to your concerns without judgment. And I hold the space for this and how we can move on together. No judgment. It is hard to find unless you understand what healthy is mean. Low vagal tone reflects diminished parasympathetic activity and is a critical biomarker for health, particularly in population exposed to trauma and obesity. It impacts cardiovascular, metabolic, and emotional function, but is modifiable with targeted intervention. However, away from all of this, away for the normal day of life, we have to have the awareness piece that this is taking place. Once you have this awareness piece that this malfunction, that these imbalances are taking place, the next step, how can I do better? what other steps I would like to take, what things I want to address first, priorities, what are my boundaries, limitations, and respect for these limitations. The superwoman, the superpower woman theory failed, doesn't exist. We would like to go back to humans. Again, in every disorder, in every DNA methylation comes, because it's all correlated with oxidative stress, inflammation, hyperarousal. It's all cascade because it's all biosystems. So what are you feeding your biosystem? What are the stimulus and integration? It is based on your pathophysiology or pathopsychology. What will gonna be manifest is based on your predisposition. So if they are predisposed to increase in weight and obesity, that will weigh. If you are going to be predisposed to the depletion of your thyroid function, that will be this way. And the list goes on with other conditions, cardiovascular, cancer, neurodegenerative, all of this, it's a cascade. It is not built in one day. What is the input? What is the environmental narrative? And environmental narrative, it has a lot of modifiers, lots of context, lots of differentiator factors, not only the risk and protective factors. There are differentiational factors. What are they? Based on race, age, gender, sex, ethnicity, beliefs, attitudes, attributes, and the list goes on. The demographic and geographic state, the language, and all of that, the communication, what pattern of communication they are adapting or maladaptive. Your body language should present your sympathovagal tone for those who are tuned into it and understand the even in your or in your way of attending to a specific situation. It tells a lot. And when there is a lot of dysregulation, it impacts everyone around. The brain infuses immune response due to the the stress at your brain immune system is activated to fight for something you didn't do, but you are witnessing. Imagine that. That is like mind-blowing. So are we seeing the brain metabolic management and the immune system management in the brain? Are we aware of that? Are we aware of these mechanisms? So DNA methylation is a key of epigenetic modification involving, this is like every time I bring DNA methylation, DNA demethylation, yes. Modification involving the oxidative stress and the inflammation master players. The addition of the methyl group CH3 to the fifth carbon of the cytosine bases, primarily in CBG denucleotides. This generally suppresses gene expression by restricting access to transcription factor for DNA. DNA methylation is the process of removing methyl groups from methylated cytosines, leading to changes in gene expression. It can occur passive demethylation, occurs during DNA replication when maintenance methylation is inhibited or absent, resulting in dilution of methyl marks over cell divisions. Active demethylation, enzymatic removal of methyl groups independent of replication involving oxidative and base excision repair pathways. Active DNA methylation is primarily mediated by TET or 1011 translocation family of enzymes TET1, TET2, TET3. Oxidize 5 methyl cytosine, cytosine 5-MC to 5 hydromethyl cytosine or 5-HMC, further oxidize 5-HMC to 5F C and 5-CAC. These oxidized derivatives are then excised to thiamine DNA glycosylase or DTG and replaced with unmethylated cytosine via base excision repair. Gene regulation, DNA methylation enables activation of previously silenced gene during development, cell differentiation, and in response to environmental stimuli. I may focus now the environmental narrative with all its differentiational factors, which is complex. It is based on what context is given. During sleep, during respiration, during introducing the stimuli, during environmental pollutant or biochemical exposure. It's a lot to take in this era. And right now, environmental medicine is on highly in demand, highly, because your ecological system is interacting with everything. So it's not anything that you can ignore. Neuroplasticity and memory, dynamic methylation and demethylation in neurons regulates synaptic plasticity and memory formation. The ability to perform under stress or exposure to stress is all of that, or after recovery from like a surgery or a viral infection or anything, you need this resiliency. Cancer and disease, apparent DNA methylation, demethylation patterns can lead to oncogene activation or tumor suppressor gene silencing. DNA methylation in stress and trauma. There is an emerging research shows that environmental factors such as stress, smoking, and adverse childhood experiences can influence DNA methylation patterns, including methylation, particularly in genes related to stress response. Like NRC31 in glucocorticoid receptor gene, exercise has also been shown to induce DNA methylation in muscle tissue, which may underlie some health benefits. Aerobic exercise. Understanding DNA methylation mechanisms paves the way for developing epigenetic drugs, DNA methyltransferase inhibitors, that can indirectly cause the methylation. Lifestyle interventions, exercise, diet, stress management, and I'm saying stress reduction. Understand the stress reduction. Understand your priorities, your limitation, what you can say yes to and what you can say no to. Avoiding any past patterns that work against your health. It's to promote beneficial epigenetic remodeling. The DNA demethylation and obesity. Obesity is linked to widespread of epigenetic modification, the gene environment phenotype, genotype phenotype interaction or interplay, including alterations in DNA methylation patterns in genes regulating metabolism, inflammation, and adipogenesis. Emerging evidence shows that active DNA methylation contributes to the dynamic regulation of these genes. Exercise-induced demethylation in skeletal muscle, a gene enhances metabolic function and insulin sensitivity. Obesity-related chronic inflammation promotes apparent methylation cycles in adipose tissue, influencing genes like BBARG, peroxisome proliferator activated receptor gamma, which regulates fat cell differentiation. So I'm saying the differentiator factors. This is important. So BBARG, one of the differentiation factors in obesity. I have to highlight it. Yeah, sorry. So dysfunctional demethylation in hypothalamic genes may also impair appetite regulation. So dysfunction of the methylation, so overeating, overcaloric intakes, and weight increase. DNA methylation for cigarette smoking causes genome-wide changes in DNA methylation, including methylation of specific loci associated with detoxification, inflammation, and carcinogenesis. Smoking triggers oxidative stress and inflammation, leading to TET enzyme activation, which can cause active demethylation of critical gene like AHRR, involving in xenobiotic metabolism. Demethylation of immune-related genes can dysregulate immune responses, increasing susceptibility to arteriosclerosis and lung disease. Epigenetic changes can be partially reversed with smoking cessation, indicating the dynamic nature between DNA methylation and demethylation. DNA demethylation and ACEs, early life childhood adversities or trauma and stress from ACEs induce long-lasting epigenetic modification. It's epigenetic imprint. It leaves the biological imprint on the person, including altered DNA methylation and demethylation in stress-related genes. Glucocorticoid gene receptor NR3C1 shows dynamic methylation, demethylation changes affecting the HB axis and stress reactivity in individuals with trauma exposure. Demethylation in promoters of gene regulation immune function, FKBPS, may lead to heightened inflammatory response and increase the vulnerability of psychiatric disorders. And this is one of the differentiational factors. It's not only what you eat, what you drink, and what make you eat this or drink that. So these epigenetics changes influences neurodevelopmental and emotional regulation, linking to ACEs to later obesity and metabolic dysregulation via altered stress physiology. DNA demethylation serves as a dynamic epigenetic mechanism, and that is one of the differentiational factors. When we would like to address, we would have to address DNA demethylation. And what is the epigenetic predisposition or the glucocorticoid factors. that can be influenced by, and the neuroendocrine as well, by environmental exposure like obesity, smoking, and ACEs. These factors modulate gene expression involved in metabolism, inflammation, stress response, and disease risk, with potential reversibility through behavioral or pharmacological interventions. So the integration between the biomedical and the lifestyle medicine is a must. Nothing work in singular. If I am giving one only, it is partial. It is not integrated. So integration present a benefit in the process of better outcomes, better quality of life, better remission of any of the level of oxidative stress or inflammatory cytokines, to the management, the mitigation. Exercise intervention in obesity, like demonstrated that acute aerobic exercise induced DNA demethylation in promoter regions of metabolic genes like PPAR, GCA1A in human skeletal muscle, enhancing mitochondria biogenesis and insulin sensitivity. This is better energy, better function, better muscle tone, a lot of better quality of life for the human. Participant, participation of 45 minutes of cycling, maximize the muscle biopsies, pair and post exercise, showed rapid demethylation within hours. Improved metabolic gene expression correlated with epigenetic remodeling through lifestyle changes or interventions, suggesting exercise potential to reverse obesity-related methylation patterns. DNA methylation changes at smoking-related loci, AHRR, in blood samples from smokers undergoing cessation programs. And it takes like 12-month study to understand the behavioral outcome of the intervention. Partial reversal of smoking associated DNA methylation changes was observed with months of quitting, demonstrating epigenetic plasticity in response to intervention. Psychotherapy, like a 12-week intervention of trauma-focused CBT with the pre- and post-treatment blood sample of hyaluron analysis. The outcome is that symptom reduction correlated with normalization of NR3C1 methylation levels, suggesting psychotherapy, talk therapy can reverse trauma-related epigenetic markers. What doesn't find itself in words, find itself in organs. Weight loss programs focusing on Mediterranean diet. It is one of the best high recommended diets, Mediterranean diet, in obese subjective measuring, because it has variety on a spectrum of essential fatty acids, proteins, and vitamins, mineral, and everything. It's if it is done right and with the right proportions. Measuring methylation changes in inflammation and metabolic gene. A 12-week controlled diet intervention with methyl profiling of adipose tissue biopsies. The outcomes of significant DNA methylation modifications were found in gene linked to inflammation. Tumor necrosis factor alpha highlighted a diet role in modulating epigenetics. There are specific micronutrients, phytonutrients, and this is, I'm going to write it down, micronutrients and phytonutrients. Because sometimes what you eat probably is not the best thing you eat at this time. And eating is, it is based, if we correlate it with what makes my body feel better, how can I function, what is the level of my attention, what is the level of my understanding of the environment, and any input around me, we call it the ability to read the room, because abilities reading to read the room is not fixing anyone, it is focusing how you regulate your central nervous system, even if, and this is on training, this is on training. Nobody is born like, oh, I am the best perfect equation of the balanced central nervous system. It all takes input and training, repetition, understanding, exposure for the right stuff, not the wrong stuff. So it's interesting how we understand things, like things are taking, words are being repeated, many words are vague, some of the practices, like it doesn't give you sense of a long term uh, outcome. It is temporary, it is superficial, but I'm doing it to feed the sense of comfort or escape, that is ease at this moment. I don't care after that. But after that, you are left with what you have. So deal with that. So if you are not addressing what already has been compromised step by step, and understanding what, where is the rupture is, and working on what make a better outcome this day at this moment, so gradually 5 years, 10 years, you are going to be the better self, the better whole human that is focusing on the right stuff, not the wrong stuff, to take in or to observe, not observe, by the way, to observe. You have to be, most of the healthy people, they are selective, not a broadband. They are selective, not a broadband. So, or a wide band. So, figure it out. You take your, you make your own decisions based on, are you happy where you are? Do you really feel the sense of true self, or are you putting more masks into your life to numb, to project, to do whatever is maladaptive behavior you want to take? But it is temporary, it's not lasting. Yeah. Cycling now, it's really interesting. One of the skills, lucky are those who try doing it. It's only 5 minutes cycling. It improve your parasympathetic tone. So this is the calm down. We need it most of these days. For example, the psychotherapy targeting like the trauma-related epigenetic changes in BTSD-focused CBT. And in many of the studies, they say PTSD, it is just a compromise that the hypothalamic, the overactive hypothalamic pituitary adrenal axis, hyperactive amygdala, compromised prefrontal cortex, and it is this flashing, living experience that it's hard to fade. And this is based on the dysregulated central nervous system from 10 weeks of neural tube And unfortunately, the psychological endurance and the psychiatric screening, especially for those who are predisposed to have such with the biomarker of the hyperactivity amygdala, the shrinking of the hippocampal, the low density gray and white matter. We don't go through all these sophisticated neuroimaging, serologic testing, other lab works that integrate that. These are at high risk of BTSD or CBTSD. The complex BTSD, it is relationship, it is correlated with toxic emotional load and unhealthy interpersonal relationships and the trauma bleeding. That is a whole in and very dense, and it can present itself and masking in many ways. Um, Either to be the victim or the aggressor. The victim, it presents itself with extremes. It presents itself in self-harm, in suicidality. It presents itself in eating disorders, in unsafe sexual relationships. It presents itself in many behaviors, and unfortunately, we want to be more open, because are you want to be a compromised human, and what function it serves for you when you have a compromised human, or are we feeding on each other? So we are living in the animal kingdom. The load of trauma and toxic emotional load has already been witnessed in and at more level and many levels um, of the human condition. So would like not to allow our children, young adults, to be on the same vicious cycle of pain and harm. Be aware. As I'm saying, behavioral counseling, yes, currently I'm studying motivational interviewing, and I'm trying. It is a tough. You say health behavior change. It is not easy, because what exactly, there is a lot of things to take in. There is a lot of factors, and humans are not trapped in very narrow factors, so that we are designing a whole different approach to their life, or coping skills, or stress management. Um, it has to be collaborative and multidisciplinary, and seeing the point across discipline. What are the master players, and what can we address first? For smoking, for example, the pharmacological therapy like nicotine patches or gum or medications as appropriate. Blood saliva sampling as a baseline for 3 to 6 to 12 months to measure methylation at smoking associated loci. So what are the matrices is here: self-report, biomedical verification, like a CO breathe test, and cotinine levels, DNA methylation changes at target loci, physiological assessment for craving and withdrawal severity. Women exposed to ACEs often adopt emotional driven eating. experience reduced sleep quality, and avoid physical activity pathway that mediate weight gain and obesity onset. Uh, some ACEs subtypes like neglect, physical abuse in girls tracked with greater obesity risk during adolescence and later adulthood as behavioral coping habit form over time. The lag between ACEs exposure and obesity often spans 2 to 3 years, meaning changes in behaviors accumulates before weight differences become measurable. So there are a metabolic dysfunction is occurring, it's taking place, it's changing the makeup or the tapestry of the gene expression and the genotype phenotype correlation. And then it takes years for the right formula for the allostatic load to manifest. But who's at risk? It's based on family history, socioeconomic and demographic factors, gene testing, and things like that. Um, Other studies found that youth into adulthood found that combined sexual and physical abuse strongly predict incident severe obesity in non-minority females, but not among minority females, highlighting race-based differences in risk trajectories. Um, there is a need for culturally tailored intervention. Some groups may show resilience and buffering rooted in cultural norms, family structure, or access to protective sources, while global meta analysis report elevated obesity risk across regions, regardless of economic development. Specific ACEs obesity relationships can vary by culture or ethnicity, reinforcing the intervention strategies must be context aware. Be aware. Like differentiator factors, like we have 4 ACEs or more, double obesity odds, physical or sexual abuse is stronger in women. Premenopausal women, subcutaneous fat, low sympathetic activation, postmenopause, visceral fats, elevated sympathetic nervous system tone, emotional eating, poor sleep, reduced exercise as mediators. Non-minority females show stronger abuse linked obesity variation suggests culturally sensitive intervention. And exposure level matters, both in quantity and type of ACEs with sexual and physical abuse, showing particularly strong links to obesity in women. Shifting adiposity patterns and metabolic hormonal regulation in ways that amplify obesity vulnerability and among women with ACEs histories, especially for more than 4 ACEs. Behavior adaptations like emotional coping via food or inactivity is a critical intermediate steps linking trauma to gain weight. Ethnic and the culture context shapes both exposure outcomes and the impact of trauma. So intervention must be adapted to culture norms, community strengths, and demographic specific vulnerabilities. Like clinical trials, they try to address pathways linking to adverse childhood experiences, obesity in women by targeting emotional eating, trauma, coping, and behavioral mechanisms. Preventing emotional eating routines. So, part of the interventions targeting adolescent girls in their parents, integrating emotion regulation skills with behavioral weight loss methods for 4 months. Overweight or obese participants in the program significantly reduced emotional eating and showed the trends toward weight loss and improved emotional regulation, suggesting that early trauma informed family interventions can reduce eating behaviors linked to ACEs. We now into the approach of collective, communal, and family intervention. You don't treat only the person and you bring them back to the same environment that triggers their metabolic dysfunction. It has to be a whole family, whole community, whole collective, like population at risk. So it has to be addressed as a whole, not a part. Dealing with the same person and bringing them to the same highly stress induced environment, their body is gonna replicate the same baseline they're activating from sympathetic response and low vagal tone, increased inflammatory cytokines, chemokines, and oxidative stress, DNA methylation, demethylation, silencing, and dysregulation, and epigenetic, like it is a cascade, it's a vicious cycle because already the programming of the cellular mechanism has already altered or ruptured. For example, random clinical trials, specifically among African Americans, adult women, with BMI higher than 36, because higher than 30, that is obesity, or 29 BMI. Comparing the standard behavioral weight loss therapy to an enhanced model with emotional eating management skills. You deal with emotions, you deal with disruptive patterns. You deal with emotions, whatever doesn't find itself in words, find itself in organs and metabolic dysfunction. Both groups lost roughly 5.8 kilo over 20 weeks. With no significant differences. However, adding emotional eating specific strategies did not decrease outcome short term, suggested that standard programs may already help reduce emotional eating. Indicates emotional eating training may need longer follow up of trauma specific content. So we have to address what is the rapture, what the context and the type and the duration of the trauma matters. A person already have a sudden onset of traumatic event, it won't be treated like this a long-term exposure. Long, it is disrupted, it is altering the human. Mindful eating and acceptance and commitment therapy, mind body food intervention, combining intuitive eating and acceptance and commitment therapy skills for middle aged women designed to decouple eating from emotional triggers. So, um, the approach is promising for enhancing psychological flexibility and reducing emotional trauma driven eating. That is the use cases. Yes, I understand that there is a point of elevation and there are points of alleviation. Sorry. And I am trying to find the balance in between to find my operating point, and that is another pattern is gonna be trained on to change or decode the maladaptive pattern in from the basal ganglia, hippocampus, and the overactive amygdala, and the alteration of the hypothalamic pituitary adrenal axis. So all this will be integrated. So when I am using intentional uh, and acceptance, I'm not putting shame, guilt, fear, or any other of unhealthy schemas that has been taking place for a long time and disrupted my homeostasis. And here I am a dysfunctional entity, internal and external, and interrupted my life entirely. And over time is leading into neurological disorders, unexplained, uncured disorders. The more of the genetic mutation and silencing and disruptive of the homeostasis. So acceptance of the rapture is part of the awareness. I understand this is how my body functions right now, and this is where I am, and it is possible to change over time, and I have to accept that, and I have to proceed with what works from now on and give away what does not work. The temptation will present itself, because whatever is dysfunction is feeding on dysfunction. It's not feeding on a functional system. It's feeding on dysfunctional. So whatever is triggered is gonna seek what is triggered. So and they see the combo love misery. Say yes. Whoever is not happy likes others to be not happy. Know that. Hurt people because they cannot numb the pain. They numb only the pain by harming others. So we have to be aware of that, and this is part of the sympathovagal language is presented within the environment. Acceptance-based behavioral treatment, or ABT, versus ABT is especially effective among those with high emotional eating, depression, or cue responsivity. So the conditioning, this is happening, that will happen. This will happen, it's happening, that will happen. I know it. Done, done, done. So this is allowing your body to act on old programming, malfunction programming, and your brain doesn't know exactly is happened today or now it's happening. So activating the sympathetic or the low vagal tone and repeating the maladaptive behavior. Um, Acceptance-based approach help women with emotional eating and perhaps ACEs histories. Diet and exercise. For randomized clinical trials for 12 months, diet and exercise intervention reduce the emotional uncontrolled and binge eating scores and improve the restrained eating, yielding weight loss. Exercise alone did not change eating behaviors. It's all integration. It's system integration, system integration, system integration. I say it once again. It is, you are not a single entity. You are matrix. You are complex. You are network. You are dynomes. You are connectomes. You are biosystems. And all this is signaling. And there are cross guards in each point. They are checking, oh, what is happening? So pass or not pass? Are they are overwhelmed or overloaded or sensitive for more to take in? So there is going to be a metabolic dysfunction and disruption occurring to the cellular communication and the interpretation of the input. Sorry. So the diet intervention alone combined is not. So it's integration, system integration, system integration. So structured dietary programs can modify maladaptive eating behaviors linked to emotional dysregulation, which may trace back to trauma or ACEs. ACEs exposure was common and associated with psychological symptoms. Having supportive relationships during childhood or adulthood was linked to better outcomes, lower BMI, and fewer binge eating, anxiety, and depression symptoms. And I mentioned before, one responsible adult. You don't want need the whole world. You don't need the whole world. But however, this trust and safety issue, it is maladaptive behavior. It is this sense of agency that something is wrong is going to happen. These are all biological programming and are embedded within the neural circuits. How can we create this safety from early age? Safety and trust. And once they are not in place, it is hard to bring them back. Let us see. Supportive systems or strong support systems had improved post-surgical results. Social and emotional support systems and trauma screening and therapeutic planning before weight loss surgery can mitigate ACEs related obesity risk, because it is the cellular language, the cellular communication. Your cell has a memory. With every compromisation occurred, your cell has a memory. If you are doing superficial intervention, the memory is going to be triggered in any way or form, and the metabolic mechanisms is going to take place, whatever it is, dysfunctional or balanced. A recent narrative review from 2017 and 2022 of digital health technologies for ACEs mitigation in youth emphasizes that digital screening and resilience building up tools can bolster mental health and prevent downstream health risks. When I say downstream, this is pathophysiology. This is the pathophysiology and the neuroendocrine disruption. While focus on mental health rather than weight outcomes, such as tools could be adapted for ACEs-linked obesity prevention, especially targeting emotion regulation and resilience pathways. Group-based trauma-informed intervention, such as TAMAR or trauma addiction, mental health, and recovery, though not weight specific, provide frameworks for psychoeducation and expressive therapy group interventions for trauma survivors, including women. These models can be adapted to integrate weight-related component, emotion regulation, and support for eating behavior change in ACEs exposed population. Acceptance-based cognitive emotional therapies are particularly effective in reducing emotional eating among women prone due to ACEs. Diet-focused programs that incorporate self-monitoring and problem-solving can yield meaningful changes in emotional and disordered eating. Family-based and digital tools over promising scalable approaches for younger women, adolescents with ACEs exposure. A pre-surgical psychological evaluation should include ACE's history, bolster the support structure to improve weight loss outcomes. Culturally sensitive adaptations and flexible model moods in person, online, or group enhance engagement and impact. Detailed intervention protocols and outcomes matrices for trauma informed and emotional eating, targeted weight loss interventions with confirmed data on effect size and follow up duration, and particularly relevant to women with ACEs exposure. Acceptance based behavioral weight loss. Um, like for 12 weeks, integration of acceptance and commitment therapy based behavioral weight loss therapy for overweight obese women with high emotional eating, internal disinhibition. Weekly session focused on values driven behaviors, mindfulness, acceptance of internal cues alongside standard behavior strategies. Among completers, 6.6% of body weight loss at post treatment, rising to 9.6% weight loss at 6 months follow up, though attrition was roughly 52% at that point. The compared acceptance-based treatment versus the standard behavior weight loss, it needs more longitudinal studies to see the impact of acceptance-based treatment versus standard behavior. Affective emotional eating, or EE, is standard mean differentiation of 0.99. Weight loss is a key factor to behavior change techniques linked to greater weight affect emotional eating change. Identity reframing, as I mentioned, whatever identity you are putting at this time, with whatever contextual experiences you are going through, that is not your true identity. This is a survival identity. Humans adapt to multiple identities, falsehood, um, self-deception, and maladaptive behaviors for survival. And when you act from a survival mechanism, that is not life. It is very chaotic, disruptive, and imbalanced, and it doesn't bring peace. In healing, you witness peace, that even there are things you need to work on, you are at peace with it, and you are working with it with acceptance. And that is the process of healing and part of the awareness. What is your responsibility of the equation? Behavior-based weight management interventions produce a small to medium effect size to improvement in emotional eating and uncontrolled eating and restraint. Effect of weight gain loss were more pronounced at 12 months post-intervention, while emotional eating improvement peaked earlier, around 3 months. Some other factor that when you, because we live in a world of quick fix, give me the solution, I want it to disappear tomorrow, this issue. But what took years? What do you think? What built up in years is going to be disseminated in one day? Or you would like to restructure and re-understand and recoding different behaviors to send the right signaling to your confused matrices of cellular mechanisms. You would like to infuse that decoding of the The miscommunication occurred on cellular level. So you would like to enter a different set of data, different set of behaviors, data center of acceptance, and attenuation to what you really want to work on, and small steps. Slow and steady win the race, as we mentioned. Slow and steady win the race, and forcing something to happen, and it is metabolically misread and not observed and not taken or carried out on a cellular level, it can reverse, and it presented the same results you struggle with over and over. So looking at what exactly the actual practical, the most targeted master player I have to address. Um, uh, there is part of peer program and adolescents, girls and parents, the family intervention, because you all impact each other, your frequencies, your energy level, your stress level, your level of attenuation, and psychological distress you feel in each other. So you don't take the person and put something and you go back to the same environment. It what do you expect? So it's a 4 month intervention and included emotional regulation skills, behavioral weight loss strategies, and parent involvement, like attachment. There is separation, there is disruption, there is dysregulation. And then I want to bring this to the state of regulation. It takes time and intention. The intervention shows that significant reduction in emotional eating and trends toward weight loss, and improve the emotional regulation, feasibility, and acceptability confirmed. No effect size data reported, because the outcomes, what is effect size? And statistically significant, not mean, but practically significant. Statistically significant, that is what the numbers say and show. However, in real world application, we work with diversity, we work with complexity, we work with context. Context can be differentiational, and the environment can be differentiational. So we are working with other input that will impact outcomes. So you work like statistically and mathematically well. However, in real world, it's gonna present, okay, let us put it into application, make it a pilot test, or make it like the early bird adopting the test. So, but the general outcomes, I don't know it yet, unless real world application took place. We see it in wearable. People have to try new technology to see how they impact their healthy behavior and maladaptive behaviors, and how to cope with whatever they want to work on, and they see the outcomes of these wearables, and these are like electrobiochemical intervention assisted devices. So still technology is going to play a role in intervention. For lifestyle, that is, we go back to the basic science. From translational medicine, we go back to the simple science, the simple equation. And what are the ancestors? Part of the approach and ancestral intervention. What your ancestors, what foods they used to eat, what traditions or rituals that they used to do when they are faced with these challenges, what tribal modulation they used to take. And this can take the phase of intervention from cross-cultural approach. Some indigenous cultures, they started to do the healing process, but you have to correlate with genetic predisposition, with your ancestral lineage, what they used to do when. And you go back this to indigenous practices, but this is from ancestral. It is not every, like, say I'm not belonging into this indigenous tribal group, but what are the practical methods that I adapt, I can be generalized over cultures. Not every single practice, not every single intake they are taking, because this goes back to their lineage, because their intergenerational trauma, their predisposition, and their allostatic load, it is cascade and it is built up. So I go back to heal the intergenerational trauma that is already assigned to this race, ethnicity, gender, race, or affiliation. So this is another like approach of healing among indigenous cultures. Uh, Look at your ancestors. Look at your ancestor, whatever your ancestor, your genealogy. So look at them, their way of life, their way of health and healing, their way of thinking, their way of belonging, their way of commitment, and how their type of service were interpreted in their community, and how they dealt with conflict, because this is you inherited part of it. You inherited part of it. And whatever, like, it was displacement, migration, immigration, and all of that, people are dislocated in many places. So this changes the ecological system in your biosystems. So you have to understand what stressors, what pressures are being externally influencing the biosystems and impacted the central nervous system regulation. It's all cyclical. So long-term behavioral lifestyle programs show particularly strong outcomes among women with childhood adversity, even after 6 years, suggesting both responsiveness and resilience in groups. Lifestyle medicine is not a luxury. It's a must, because it's all around you. Whatever invaded your biosystems externally, you can go make an inventory of it. This disrupted my amygdala. This disrupted my immune system. This disrupted my neuroendocrine pathophysiology. This disrupted my mental and emotional regulation. There are factors we invite into our life, and unfortunately they lead to rupture and disruption. So you take an inventory of that. Take an inventory, what disrupt and what interrupt, and how can I bring balance to this disruption or rupture. Uh, Another point is emotional regulation, modulation. So that's a big word, but however, it happens. Your emotions are interpreted on your electrobiochemical systems. So on a cellular level and molecular level, it's changing the person over time. Several research-driven protocols targeting emotional eating and obesity, especially relevant for women and youth with a history of ACEs. These modules were integrated into behavioral weight loss or obesity treatment, and are grounded in evidence-based framework such as DBT, ART, and mindfulness. All comes with a clear session structure and outcome matrices. It's a multidisciplinary approach. So emotional regulation training, it's a multidisciplinary approach. It has the treatment plan or intervention, or the care treatment plan. It has to be from transdiagnostic, multidisciplinary, and across sections of points that identifying the master players and the differentiation factors. So from this, this intervention, multidisciplinary obesity treatment intervention plan, it shows that improved emotion regulation competencies, emotional awareness, problem solving, evoking positive mood, if effect is maintained at the follow up, because you're doing intervention, you're seeing the outcomes, the follow up, that what keeps the consistency and the persistence of the new inputs. So the change take place, and it is long term and stabilized, so it became a second nature, but it's a good intervention and a good modulation. Reduce emotional eating and improve the general well-being on, and it presented long-term care gain. Sorry. So whatever change is happening, if it is a short-term effect, that is numbness, and that is quick fix. I'm looking at the long-term gain, and this is including the reward punishment system, or the reward system, like in addictions. Whatever habit I'm doing, it is already embedded in the basal ganglia. It is already coming into the episodic, implicit, the short term, the long term memory, whatever sections it's happening, it is repeating itself autonomically. So you are running on autopilot. Like the regions like the reticular formation as well. The tegmental area. So lots of areas, uh, areas that makes why the maladaptive behavior persists, whatever it is, emotional, psychological, physiological, whatever it takes place to numb or to drive away of the point of discomfort and disease. DBT, basic emotion regulation training, computerized adult with dietary restriction risk. It contribute to emotion regulation modulation adapted into computer or PowerPoint with interactive worksheets. Is mindfulness, emotion identification, noticing and redescribing judgmental thoughts, behavioral regulation techniques like distraction and opposite action, emotion acceptance to prevent a restrictive dysfunctional eating, improved emotional coping skills, participation, applied these strategies during and observed the test meal, no long-term weight outcomes tracked. Mindful-based emotional eating awareness training in young adult women for 6 weeks, group intervention, focus on psychoeducation about emotional eating, mindfulness meditation, intuitive eating principles, and stress awareness and impulse control training. Mindful practice embedded in the emotional eating context, balanced training on inhibitory control, behavioral task, and emotional impulse regulation, intuitive awareness around hunger, fullness cues, reduction in emotional eating and food cues reactivity, increased mindfulness and intuitive eating awareness, improved impulse control or behavior measure. It's, however, no formal weight loss tracked. So when we understand the intervention, it has to take a shape or form of research setting. You have to see the baseline and what intervention and the modulation and adaptation of this intervention over time based on the context and where they are, meet them where they are, and then taking another onset or set of information and compare the past with the present, and this will redirect the decision making and the perspective strategies or coping skills that needs to be. I don't repeat the same coping or strategy over and over if they don't work, or if they don't over like 12 weeks or 6 months they didn't present any significant practical, I say statistically significant. It doesn't mean real world application significant, or practical approach is significant, or evidence based approach is significant. So I have to understand what is the change, what are the actual tangible changes occurred, and if it doesn't work, so it doesn't work, so move on. So you have to be adaptive as well in the approach of intervention. It is not about that we are failing. It is what we are seeing. What is the best practice from the perspective of the patient needs, the person needs, from their own perspective and their own understanding and collaboration and interaction within their treatment plan. They have to have their input. This works for me. This does work. I would like to, and moving on. And understand the sequence of the strategy within the context, within the given context. When they are among their peers, it is not among their families, not the same. It's not the same, different dynamic, but psychological arousal is happening among a group, among a setting, places, events, anything like that. Everything is changing, guys. Uh, uh, there has to have emotional awareness and labeling, like identifying the triggers and signals, the shifting between cognitive appraisal and judgments, opposite actions versus emotional eating coping, mindfulness and urge surfing techniques, self-compassion and acceptance skills, problem solving and planning for high risk moments. There is relapse. There is going back to the old for the comfort, seeking comfort, the familiar, seeking the familiar, building positive mood and resilience, consolidation and relapse prevention, integrating real life examples tied to ACEs related triggers like emotional arousal from stressors in daily life. Utilization of brief mindfulness practices from 5 to 10 minutes in each session or day of the person's life, including home practice assignments like daily emotion logs or urge surfing videos and self-compassion journaling. Emotional regulation modules drawn from DBT and ART frameworks reliably improve emotional awareness, impulse control, and adaptive coping. Modules embedded within weight management programs, multidisciplinary treatment to show better outcomes for emotional eating. Targeted use in women with ACEs exposure holds promise. Addressing trauma-linked emotional dysregulation may interrupt the pathway from ACEs to disordered eating and obesity. Adaptability. So adaptability, like what is it in group format, is online, virtual, individual therapy, or tailored or culture, age, specific context. Trauma-informed sessions to adapt from established emotion regulation intervention. or relevant to emotional eating and obesity in women, a history of adverse childhood experiences. Opposite actions, planning for emotional eating. So, what should I prepare myself? Neuromuscle, this developing the neuromuscle. What should I do when? What should I do when? And try to put reminders or cues that this is what I would like. This is the opposite action, or this is the behavior I would like when I am triggered, or when I have the impulse or the urge to do the same behavior. I'd like to um, I'd like to deviate from, and driving harm to me and others. So self-awareness is critical. The awareness of the triggers, awareness of the context, awareness of the situations, awareness of the environment, awareness of the input is important. So, for example, part of it, like say it aloud. I notice. So the word is like I notice. I noted that I have. I am impulsive about eating more, or driving to eat this and that without a thought. So to. I have to allow this feeling to pass by me. I'm not focusing on it. I notice, I allow it to pass. And whatever you don't put attention to will not have value on your behavior, by means or influence on your behavior. You give attention to something, it will take place. You are giving it value. When you give something attention, you give it value. But you don't give attention to it, you don't give it the value. So you want it to pass. You notice, you acknowledge, let it take its cycle in peace. Let it pass by. Acknowledging that what I'm going through now is difficult, but I choose. This is determination, attenuation, this is focus, this is problem solving. I choose to treat it with care, not criticism or judgment. So I'm not putting the perpetrator wish that I'm going to put shame, guilt, fear in the sympathovagal response, or fight, flight, freeze form is taking place. So I'm going to drive from the old that I notice, I observe, I'm allowing it to be, and what I want to change right now. It's difficult. I understand. I acknowledge. I notice. I I treat it with care, no criticism. Try the best this mental neuromuscle to adapt instead of allow the overwhelmed central nervous system response to take place, which doesn't serve you, doesn't bring you in a good place. This overactive immune system, hyperarousal, hypervigilant, impulsive, and the list goes on. That's not a better place, not a healthy place. And it is impact not only you, it's impact anyone coming in communication with you. Uh, the guilt of like the perpetrator would like to remind you of your past, like to remind you of your failures, remind you of your weakness, remind you. So working on your open wound. So when you have an open wound, it's keep like bleeding, and it is harming. The perpetrator love to keep this open wound and press on and on over, because this serves a function that it trigger the sympathovagal low tone in the fight flight and the aggressiveness, or self-harm, or the maladaptive behavior, whatever it is gaining something out of it. So ask yourself, who is the beneficiary, and does it serve you, and do you like your life like this? Um, addressing that, whatever stress on your harm and hurt, that is not a healthy person or a healthy environment or a healthy context. You are choosing to move forward. I'm moving on. I'm moving forward. This doesn't serve me anymore. That is not selfishness. That is awareness. That is attenuation. That is honoring God in your creation, because God gives you life, and life, eternal life. It is God gave you life. He doesn't give you a life that will press on in your shame and guilt and fear and your past, an open wound, and pressing on. And that what the perpetrator loves to do. Uh, so another thing, what happened in the past doesn't define me. I am not broken, I am healing. And that's a whole different language. The perpetrator like to look at you as a broken entity, because you are an object. Like in the Asian culture, when a vessel is broken, they glue it with gold, and they frame it with another purity to present it to others. Imagine this is a vessel, or this is a real object, how they treat it. So this respect, even for something once it presented a function. However, they keep this function, but in different method. Uh, Learn from those who take the good, leave the bad. So mindfulness acceptance based approaches, acceptance and commitment to therapy, mindfulness based stress reduction, emphasize present moment awareness and non-judgmental acceptance of thoughts and feelings. For many times we see, I am accepting you, I love you, but behind your back you are snatched into a million pieces, and all your faults are brought up. So this is false acceptance. These components can reduce chronic stress and improve emotional regulation mechanisms relevant to trauma and smoking cessation. Epigenetically, mindfulness practice may modulate stress-related gene expression by reducing cortisol and inflammation pathways, potentially influencing DNA methylation and demethylation in genes like NR3C1 and FKPP5 by decreasing sympathetic tone and enhancing parasympathetic activity. These interventions may alter the physiological model that drives epigenetic remodeling. Another part of the intervention is sleep, and sleep is an important. If we 2/3 of your life working, interacting, 1/3 sleeping, but with this 1/3, it count all your entire life. It can impact your state of health and disease. Uh, Missing hours of sleep, your brain doesn't make up for it. Having longer time of sleep than your circadian rhythm or your biological, it interrupts your metabolic function as well. So the balance or the point of homeostasis, it is a way of life. However, you understand that this sleep deprivation and sleep disturbances patterns, it is based on your oxidative stress, inflammatory response. It can determine either allostatic or health and disease state metabolically. Sleep restrictions and hygiene, yeah, set individualized time in bed goals and caffeine, alcohol, nicotine guidelines, relaxation exercise. This sleep restrictions. So um, it is good. Like if you, it is stated that if you are set a time for your sleep, stick to that. There are disruptions in the middle, but how you can come back to that, and that with nutrients, that with talking through it, and inviting relaxation techniques into your life so your body bring this homeostasis balance and the resiliency to bounce back or to recoup from what has been disrupted. Um, Having catastrophic challenging thoughts with the sleep, it can be met with restructuring these catastrophic sleep related thoughts. So, adopting cognitive restructuring, reframing of the thought can reduce hypervigilant reminders before bed. Because why? The enemy would like to visit you at the time you would like to rest. You would like to have peace. They don't like that, so they work on it. So, identify awareness. Nightmares and trauma management. For persistent nightmares, integrate in imagery rehearsal therapy. So guided imagery is one part of the techniques. It is very interesting. Even you see a frame or a portrait, and you go through wondering this, and you have a wandering mind through this. It distract or redirect the hyper arousal, hyper vigilance signaling, the fight flight, the sympathetic response to dampen, because you redirected the attention to something completely different. And this discomfort thinking or pattern is going to be dampening over time. Some situations, yes, there are relapse, but how you can reinforce cognitive control. This is like from cognitive control into habitual, into the 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 ease or the comfort, the attenuation and coping mechanisms. Have like if you are the person who likes to document everything, or like to take to would you like to draw the patterns of your sleep, your thought patterns, It is good to identify specific master players in these catastrophic or discomfort thoughts that trigger what time and what they do into your sympathetic response or autonomic response, and what are coping mechanisms in place. And instead, after identifying, don't go back to them like for 6 or 12 weeks. Go to what you want to take place. Took the new pattern you would like to adapt into your life. Go back to it, because you are reframing, you are restructuring your perceptual mechanisms or memory, so you can reprogram your brain understanding of what you want to do, not what has already taken place. There is a technique of progressive muscle relaxation as well, deep breathing, guided imagery, as hypnosis. I used the hypnosis for a while. I needed it, so I wanted just like things, many things that I didn't know why they happen and what happened, where I am, and why all this happening. So I had to use hypnosis, and it worked. And every time I see, like, especially with traumatic brain injuries and very heavy trauma experiences, if they are open, I say, have you tried hypnosis? Some say, no, I don't want that, but it works. I don't know. But however, when you use hypnosis, you don't drive, you don't walk, like you have to be in place that is safe and trusted, so you won't harm yourself or somebody, okay? So you are using hypnosis as a calming method of reduction of the physiological arousal, especially trauma-related symptoms. I'm gonna send a link that is, yeah, it's really, and his voice is really like it's making your mind wandering. If you are really high, exhausted, stressed, listen to one of these videos, but give it a space and time. So, and understand, is it working for you or not? Or sometimes the hypnosis for the highly arousal, it increases, like yoga, like mindfulness, like meditation, with not attenuated vagal tone. People are scared, feared, panicked. Opposite. They are scared of calmness. They are scared of silence. They are scared of being alone. They are scared to attune and listen to their breathing. This is disorganized attachment that they don't want to internally attenuated to the self and listen to their body. They are afraid. This is can be in PTSD individuals. So understand that calming techniques, calming strategies, sometimes with dysregulated attachment and hypervigilant central nervous system with like PTSD, calmness is not, especially at the first phase of intervention. I have to bring them to a process of understanding their pathophysiology first and what needs to take place and how, and walk them through this. And then when they are stabilized and they are aware of the action and the contributing to the action that needs to take place, then I can present gradually the calming, silencing, the aloneness, the time of calmness, because they are ready for that, not at the first phase. The polyvagal theory, it works part of that as well. I'm gonna bring the that is really interesting because when you are in a healing process, when you are trying to understand the human condition for 15 years right now, you study all different areas that sometimes you see, okay, they don't come together, but here from the human ecological systems and the biopsychosocial, the health behavior theories, the 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 theory and practice correlation, from transdiagnostic, from everything. You are a whole entity. You are a whole entity. You are not separated. So there are many pieces. I'm gonna bring micronutrients, phytonutrients, and their role in GI tract or gut-brain axis, gut-brain gut-brain axis, and I'm gonna send you the video of the hypnosis link. I use this at times of truly of high intense events. I don't know why they happen and how they happen, but they impacted my life deeply. And from this point, it's given me determination that if we lost the perspective of human life, what else could we have? If we lost the perspective of human life, what else we have right now taking place? Is it a quick fix? Is it a short term gain? Is it leaving tangible, practical, applicable, real world implementation? And you see a difference that correlated and associated with the modulation of emotions and the sympathovagal tone, because this is all impacting on your central nervous system and leading the orchestra of oxidative stress, of DNA methylation, demethylation, of gene expression, and the compromise of the human condition over time. Sometimes we say it's social norm, conflict, lack of support, discrimination, racism. We're good at labels. We are good at giving everything a label. We are good at that. We mastered it. As a human, we mastered it. But understanding the electrobiochemical mechanisms that are happening with that and the outcome on the lifespan and health span of the human being, that is not in the equation. We became like we promote the I don't know how I say it, the muscle strength, the coming forward as the strong, the superwoman, and we forgot the bias system compromisation coming at the expense of that. No one is immune, I'm saying. No one is immune. It presents you with an offer to take responsibility, to change this course, or you're going to fall victim for it. And you're going to repeat the same intergenerational trauma that many have still being a price for it. As you have to choose your response. Are you going to be aware? What level of your awareness, where you are right now? What systems are you operating from? And what are your coping mechanisms of emotional regulation and its impact on your central nervous system? Um, I presented in this part one and two obesity, ACEs, and and the maladaptive behavior of smoking and its impact on DNA methylation, demethylation, obesity, the adipose biology, the gene expression, and the adaptation, the maladaptive behaviors. Are you compromising what God has given to you as a priceless gift? That's your life. Or are you taking responsibility to understand to a level that you have to take action and adapt to a better methodology, a better perspective, a better approach for your health span, spreading the health culture. And what does it mean? It is not only what you eat, it is not only what you drink, is understanding the rapture and how the repair can take place. And I'm talking about the rapture gradually of every single video to understand what rapture means. It is a huge, it is the most giant onion I'm peeling. That is the human condition. And that's what I live for and what that drives me to say stop. We're not object, we're humans. We have to understand the point of intergeneration trauma and how it impacts on individual, group, family, community, society, and nation. We have to understand that it is better to have healthy people than compromised people. And peace. I am looking for the video that I want to share. The video I want to share. Hopefully I find it. So yeah, it is somewhere. On. It is somewhere. The video I want to share. The video I want to share, but use it in a safe place. You know, like maybe before bed, 2 hours, maybe before scheduled your scheduled nighttime. Maybe use it. I'm trying to find it, and I will bring it here. Here. And I hope this guy, he's from Australia. Australia. He's not here in US. Wait, yes. And uh, yeah. enjoy these videos, but use it before bed, like 1 hour before bed, the 2 hours, and just try to allow your mind to wander with it. It will redirect your focus from what is really, all this is changing you internally. So don't be your own tool of destruction. Be your own tool of healing. God loves your healing because you're healing. Many would like to witness, to have hope, and regain their humanness. Yes, I wish you well. Bye.